So my name is Sankar, and I'm from University of California, Los Angeles, and I'm very happy to be here. You're all interested in VNS, and that's what we're going to talk about. Just to give you a little background, I've been using VNS in my patients dating back to when it was first approved. So it's been around a while. It got approved in the 1990s. So you could say it's been around since the last century, okay? So there's a lot of patients on it. So we're going to share some information about what we call drug-resistant epilepsy and emphasize the point that we have done these studies, going back to about the year 2000 on. People have looked at how are people responding to medication. This is a very important study that the data has been repetitively confirmed, okay? And that is, if you make a reasonable choice of medication for the type of epilepsy the patient has and gave an appropriate medication, approximately 50% would do very well with it. They will become seizure-free. Now, of the remaining fraction that are not seizure-free, if you either add a second medication or substitute with a second medication, you typically get about 13 to 15% more seizure-free. That doesn't work, and if they are still seizing, and if you went to a third medication, at that point, your return drops down to 3 to 5%. Okay? So if you add it all up, 50% up front, let's say another 13 to 15 later, and yet another 3 to 5, you find that what you got is approximately 2/3 of the patients have become seizure-free with 1, 2, or 3 medications. Beyond that, as you can see, we went from 15 to 13 to 15 to 3 to 5. So it becomes really hard, and unfortunately, this number has not been changing. It was like that around 2000, it was like that around 2010, and it's been like that around 2020. And the studies like this are initially done in Scotland by a doctor called Martin Brodie. Later, they've been repeated in the VA population in America and general population. So we have this idea that some patients have what we call drug-resistant epilepsy, right? So for them, the chances of becoming seizure-free is not very good with medication alone. And so this is where we want to talk about VNS as an add-on option. Okay? And then you'll have opportunity to ask questions. I don't have to read every slide, but the International League has basically defined it this way, that the failure of 2 anti-seizure medications to achieve sustained freedom, as long as people didn't give you the wrong medicine, right? Sometimes that happens, and that's not drug-resistant epilepsy. That means you need a good epilepsy doctor. So that's a different scenario. But if you were given the appropriate drug, they were dosed correctly, and you have failed 2 medication, that's what the International League and the big body of epileptologists from all over the world agree, that that'll be called drug-resistant epilepsy. Sometimes it's called intractable epilepsy, hard-to-treat epilepsy. DRE is just the abbreviation for drug-resistant epilepsy. As I explained to you, that's usually about 1 in 3 patients. That leaves a substantial number in America, where we have about 3.5 million people with epilepsy, and 1/3 of it, as you can see, is more than 1 million people, right? So the goals with treating drug-resistant epilepsy are to get seizure control, reduce side effects, but as you can imagine, as you escalate drug therapy, as you add more medication or keep going to higher doses, you're going to have more side effects, understandably, right? So, and to improve the quality of life. Now, a portion of the drug-resistant epilepsy people may be amenable to what we call resective surgery, where they have a clear focus that is in an area of the brain that we say is not eloquent cortex, and they can have surgery. Okay? So, but many people will find that surgery is not such an easy proposition because their seizures are coming from a part of the brain. What we mean by eloquent is not just language. Language is one of them. For instance, if I was a mechanic and if I'm right-handed and I'm using my right hand every day to use tools, right? So if my seizure is coming right from about here on my left hemisphere that controls this right hand, you can't take a chunk of it out, right? I will lose my livelihood. I can't do what I need to do. Likewise, we can't afford to lose language, either speech or comprehension, right? That'll be like you had a bad stroke. So not everybody is a candidate for surgery, and that's where neurostimulation comes. So the risk of undertreated epilepsy is the adverse effect of meds. There is also unexpected death that you have heard about, called SUDEP. That's a real risk. The risk of SUDEP is very high for those who have convulsive seizures. What in the old days people used to have grand mal seizures, right? It's particularly high. There are what we call comorbidities of epilepsy that affect the quality of life, and depression is one of the biggies, right? Depression, anxiety in youngsters, developmental issues, right? There's also seizure-related injury. You know, people have had a seizure when they're cooking and have had, you know, hot oil all over their hands or dropped some heavy object on their toes. You know, bad things can happen. And there are issues with thinking and memory, difficulty with social interactions. An adolescent with drug-resistant epilepsy may be very reluctant to look for a job at McDonald's, may not want to date, right? There's a lot of issues. Of those, a couple of things have been of a lot of interest to me personally, and that is the idea of what we call comorbidities. You know, changes with thinking, memory, as well as depression, anxiety. So I have had my career over the last 35 years of doing both clinical epilepsy and some basic science. And one of the things we studied for almost a decade is if we take perfectly normal rats, for instance, or mice, and if we artificially give them epilepsy, they actually develop these comorbidities, okay? They develop depression. And of course, people sometimes come up to me and says, how do you know a rat is depressed, right? Interestingly, there are ways you can tell they're depressed because normally if you put a rat in a tank of water, which you may have never done, but in the laboratory sometime we do, rats turn out to be phenomenally good swimmers, okay? They paddle like crazy and try to get out of that tank, right? Now, we do this experiment for short spells with video on a glass tank with vertical wall. So you can't really climb out like you're in a lake. So what we do is we time and say, how hard do they try? So if we're timing it for 3 minutes, and then we'll take them out. We don't let them suffer, right? However, if we gave the rats epilepsy first, by a variety of methods, those rats just tread water. You see, they don't try to escape even though they don't like it. So what we call it is an animal version of despair. They have just given up. Another test we do is called anhedonia, right? Hedonia is hedonistic behavior is seeking pleasure. So if we put a rat in a cage and left 2 bottles of water, and one of them we put some either sugar or saccharin and sweeten it, you come back overnight and you find that 85 to 90% of the water they drank is from the sweetened bottle. That's normal behavior. If we gave the rat epilepsy, those rats, if we come back and check what kind of preference they had, we find that the water consumed is kind of 50-50, meaning they did not make a choice. So when they got thirsty, they went in to one of those spouts and drink whatever. They didn't say, hey, the other one tasted better, and run over there, right? So it's a lack of pleasure seeking. So we see all these. And one of the things that we have worked out over years is mechanistically what's happening with epilepsy is epilepsy through a cascade of different biochemical processes that involve the inflammatory pathway, the steroid pathway in your hypothalamus. They eventually end up affecting parts of the brain that release a compound called serotonin, right? It is serotonin that makes you feel good. And when your serotonin is in deficit, you don't feel so good. So one reason I'm so attached to VNS, I just listed here all these things with epilepsy, but VNS actually stimulates that part of the brain from which we get release of serotonin. So I kind of like the idea that it is actually addressing a change that occurred in your brain due to chronic epilepsy, and now it is chronically going to stimulate that side. And that may be why, many years ago, VNS was also approved as a legitimate treatment for drug-resistant depression. Okay? So, from a comorbidity point of view, it's a very exciting thing because we are actually attacking where there are real problems with epilepsy. Okay? So the VNS therapy now has been used in more than 135 patients, and up to 40,000 of them are children. And they have shown that in these patients, we get a better result in preventing too many seizures, and sometimes stopping them, sometimes making them short. We are getting all that without the drug side effects. Okay? So you can talk to your doctor, your epileptologist, if you're having seizures, even though you have already tried 2 or 3 medications and are not controlled. And if your recovery is slow, if the side effects are intolerable, all of those things mandate that you consider this among the options. Okay? So the benefits include fewer and shorter seizures, reduced worry about it, quality of life improvement. It just looks like one of a scattered things, but it's very close to me. Study after study has shown that these comorbidities, right, affect the quality of life. For many people, mood disorders are the biggest burden they're carrying. In the end, whether you had reduction in seizures by 50% or 70%, it doesn't make that much of a difference. But if you eliminate their depression, if they can make you learn better if you're a student, those actually have a big impact on the quality of life. And of course, with the stimulation, you are able to do that without drug-related side effects. And you can usually use, one way we know our patients are doing better is we are prescribing fewer rescue medicine, right? And, Valtoco, Nazilam, that type of stuff. And fewer visits to the emergency room, okay? So we have data that it has improved the overall quality of life with improvements particularly in memory, mood change, post-ictal period, alertness. And as I told you, I spent a lot of my time looking at these mood changes, memory issues in rats and mice. And it's really due to deficit in some neurotransmitters that epilepsy has wrought on, okay? And with children, same thing. We see fewer seizures, shorter seizures, less severe, quicker recovery, right? So it's been used for quite a while. And let me see. Go back.
Sorry, guys.
Yeah.
I know.
Yeah. Oh.
It's because it wants to play the video. See if I can get, did you see it now?
Right. No sound?
There we go.
Oh.
I didn't play it.
Okay. So with VNS therapy, as you know, the device looks like a cardiac pacemaker, if you have seen it, right? It's fairly small and thin. It sits right here on the left shoulder. It goes right about here, so it's not in the chest cavity, it's just under the skin. It's not in the abdomen, it's not in the chest cavity. No connection to the lungs or anything like that. And there's a wire that leads under the skin to the vagus nerve that runs right around here. Okay? So when you stimulate that, that nerve goes into the brainstem and it connects to two important spots in the brain. Those are actually very key for our neurotransmitter tone. One of them stimulates what we call noradrenaline or norepinephrine, and another center secretes serotonin. As you know, when people get depressed and they get a Prozac or something like that, what do? They actually enhance serotonin chemistry, right? So those centers are really important, both in suppressing seizures, but in also making you feel better, okay? So there are different modes by which VNS can be used. So that's what this slide shows. The normal mode is one where the thing is set by your doctor to come on for a certain period, like 30 seconds, and be off for 3 minutes, which is a common mode I use, even though in the initial test they went 30 seconds, 5 minutes off. That kind of comes all the time, right? The other mode is new, that's called the auto-stim mode, where now we have, VNS has also achieved a property that sometimes people call closed loop, where it's actually monitoring seizure. Unlike some other technology which has electrical leads into where your seizures are coming from, what VNS does is it leverages the fact that when you have a seizure, your heart rate goes up. So we can program it such that it monitors your heart rate, and we can set it 20%, 40%. Your doctor has the ability to set what would be a cutoff, right? And then if it detects that your heart rate does that, bing, it'll give a stimulation without you having to do that. The other one is the magnet mode. That's old. The magnet mode is still available. That has been always available since the device was very new, where you're given a magnet, and either the patient themselves, sometimes they can wear it like a watch with a magnet, and other times with some of the kids, the care provider can. And you simply bring the magnet and do this, and it'll set off a stimulus. For instance, if your off time is 5 minutes, and if a seizure occurs in between, you can trigger one. You can also set it to be a little stronger during a seizure, right? And then the auto-stim mode allows you to set it where not only can you set the threshold from the heart rate, you can set it to be different during the day and different at night. That's also important because during the day, with the activities of life, your heart rate changes more. It changes less at night. So I could say, during the day, do a stimulus if the heart rate went up by 40 to 50%. During the night, maybe 20%, right? So the night activity with the auto-stim is really important because in the old days, mothers would ask me about their children. Yeah, during the day I swipe the magnet 2 or 3 times a day. But I'm sleepless, wondering what will happen. But now we can make autostim happen, okay? So I think I already told you, the magnet can stop the seizure or shorten it or decrease the intensity and often improves the recovery period, okay? And so the technology features all these ability to, for instance, in the new devices, you can get an MRI without a problem. The radiologist has to know that you have the device. We usually turn the device off before they go for imaging, but the device can stay in place and you can still get a safe MRI, okay? There are protocols to do that. I already mentioned to you, we can do different settings for day and night, and we can schedule the programming. This is, when the device first came, to gradually titrate to a dose, the dose being the amount of current, right? We used to start with a very, very small current, and then we would say, come back next week, and I would, pump it up a little bit. So it'll take several visits. Used to be really challenging because my clinics are usually overfilled. It's really hard to find a slot for somebody. But more importantly, my patients, I practice in Los Angeles, right? It's a very large area with notorious traffic, right? So with the new device, they don't have to come for every titration. We can do a lot of it, set the program to say go up by, 1/8 of a milliamp every week and do that for 2 months and then come back, right? And if you have any issue, you can call me. So the scheduled programming, day and night programming, these are all the new features that were not initially present. The procedure is an outpatient procedure. Patients usually come early in the morning, and typically they leave midday. Our procedure, they usually come in at 7 o'clock in the morning or something. The surgeon implants them. Takes somewhere between 1 and 2 hours for the whole process. And then they come to the recovery room. And if I'm rounding in the hospital, after I've seen all my patients, by midday, I would wander by the recovery room and, make sure they are okay, set it, and then they're good to go. Okay? And so it's really a pretty straightforward thing. And the battery can last, the slide says 1 to 10 years. Honestly, I have never had anybody burn through it in 1 year, nor have I had anybody last 10 years. But how long depends a lot on the settings, right? If you are having it frequently and a lot, it's going to burn through quicker. But I would say my most high intensity usage has still gone for a couple of years. And it is rare that people have had it more than 5 years. Somewhere in the 4 or 5 years, we have to replace the thing. And a lot of time people will use the lay language and say, I need a battery change. But remember, the device is a little bit like your iPhone. You don't really change the battery. You change the whole device. So when you go to so it's a misnomer when they say battery change. There's no such thing. The old device comes off and a new one is placed, okay? And so what else? Yes?
The chest piece that would come out, or the whole wire?
Oh, no, the wire doesn't have to. And the wire is wrapped around, that coil doesn't have to. See, the wire actually plugs into the device. So in a sterile manner, they remove the device, put the new device, and plug in the cable. So it's not particularly traumatic. Yeah. This is an important slide. I wanted to tell you about.
Before you start, I'm so sorry.
Yeah, no, it's okay. You don't have to be sorry. You can interrupt me at any time. I'm very comfortable talking about this. I don't have to have these slides. I can have them all day.
It's just a quick question. So I know that it's for drug-resistant epilepsy. However, have you experienced or seen in clinic being able to scale back on some of those medications due to the VNS missing?
Absolutely.
Okay.
Absolutely. Sometimes we reduce the dose. Sometimes we even take one or two off. We will do all enough.
And how long does that typically take? I know every person is probably different.
Yeah, there's a lot of variation, but I would say I don't mess with their meds, I think, for 6 months. The VNS is unlike medication. Its efficacy improves over time. You know, if you look at 3 months, 6 months, 9 months, 12 months, they are still getting better. It's almost like conditioning your system. So we eventually are able to stick with our meds, but we don't do that right now. Okay. Yeah.
Two related questions.
Sure.
Is there any risk to, say, for instance, a 4-year-old and she gets a hold of, hypothetically, gets a hold of a magnet and can then,
Well,
you know,
okay,
can she overdo it?
yeah, in that age, we don't give them the magnet. The magnet stays with the faculty.
Ideally,
It's unlikely they will because, you know, they may not like the feeling of being stimulated. The thing like to get used to it. Usually, I don't know anybody compulsively turning it on.
No, good to know.
Yeah.
And then the second question.
Magnets on the corners, on the walls.
Yeah, way up high.
Like the fridge thing.
Yeah, it's amazing.
Cabinet magnet comment.
Yeah. But keep it away from your credit.
The second part of the question is, since it's inducing a serotonin response, is there a worry or evidence of it being like dependency or anything like with, I don't know, with serotonin type medications we can be dependent on them or have issues with
There's
them?
no such thing.
No.
The thing is, it's continuously on the move. You're not destroying it. But on those patients, it's a small fraction who thought it did benefit them and wanted it out. They were having
No one like overdoing
yeah.
it like that.
But because of the fact that it takes a little time, and sometimes patients underestimate the benefit. When somebody says, I want it off, I tell them, we're not sending you to the surgeon yet. I'm going to turn it off for a few years. Right? And I'm going to give you a few months. And quite often, they will come back and say, I didn't realize how that's what it was. So we'll crank it back up. You had a question?
Yes, I've had a couple patients come into the hospital where they have the VNS, but they don't have seizures, and it's used to them on the EEG, and it turns out they have PhD.
Yeah. Ideally, DNAs should be diagnosed before you do that.
So how do they actually then to look at the VNS mutation?
I would say
Wouldn't they need to diagnose epilepsy too?
they should have been better at diagnosing. I know what you mean, and I'm aware that this has happened.
Yeah.
This is also why we used to be critical of the company where it was under different management of promoting it too vigorously outside the world of epileptology. Because sometimes when you go and talk to a family practice doctor at Costa, and the original company was outside on it, that was particularly guilty. And they would go and, let's say we send a new specialist from the company to help you program. But obviously primary care people don't know how to program this. So I think for a while, neurologists and epileptologists were furious with the company. But that stopped all that. third-party payers don't want to cover. So if it's not promoted,